Councillor Vilcheck and Councillor Humphrey. Any other from the floor? No.
Have you done a friendship now?
No.
Apologies.
I've not got apologies from her. Just using of apologies, she's not coming, so she may just be on her way. Minutes of the meeting of the last Health and Wellbeing Scrutiny Committee was the 4th of April. They have been circulated. Are there any comments, or can I confirm there's a true record?
Move acceptance, Chair.
Can I second that? Yeah. Disclosure of members' interest. Has anybody got any interest to declare on this? No? Okay. Forward plan. Chris, can you take us through the forward plan? I don't think there is anything that affects this committee.
No, it's just to know there isn't anything on the forward plan that would come to health scrutiny.
Thank you. Health and Wellbeing Board, we have the minutes of the Health and Wellbeing Board, which was on the 9th of March. Is there anything, any issues anybody wants to bring up? What we need to look at, so shall we just accept them? I'm happy to accept them.
Agreed.
Yeah. Right, we move quickly. The Newcastle upon Tyne Hospital NHS Foundation Trust quality accounts. There's quite a few of you here. Could you just who's going to do the presentation?
So we're all going to present, so if we can do some introductions first off.
Okay, I shall leave you to it then.
Sure, TNT and I'm Associate Director. Any Deputy Chief Operating Officer. Louise Hall, Deputy Director of Quality and Safety.
Gavin Sanson, Head of Quality and Effectiveness.
I'm Vic Smith, I'm the Quality and Assurance Manager.
I'm Health Charters, I'm Associate Director of Nursing.
And I'm from CMTW.
Thank you. The room acoustics are not brilliant. Well, they usually are, I think, but it is a bit quiet, and we don't have the microphone system in here, so can you just sort of be a little quiet. Right, I'll hand it over to you.
Okay, well, thank you very much for inviting us to present our quality account for this year. I am aware that you've had the draft consultation document and the presentation before this session. So what we plan to do is just give a brief overview of our progress against the quality priorities from this last year, and just to present on the proposed quality priorities from for the coming year. So I'll hand you over to Cheryl, who will bring back the first slide.
So our first priority was completing healthcare acquired infections, which is obviously all the same, something that we want to prioritise in terms of so we looked at COVID-19, believe it or not, it's still around very much so. We've got 30 inpatients currently, which is half of what we had a couple of weeks ago. However, we have had a return of flu this year and norovirus certainly, and we've been very challenged over the months of that. But really strong infection control team and teams on the wall have managed to minimise that as well. From a MSSA bacteremia point of view, we've got an internal 10% year-on-year target for reduction. We've got no national trajectory this year, however, that was also as a trust wanted to have that reduction, which we have achieved. Gram-negative bloodstream infections is something that, from a national perspective, it's a real focus to have that reduced. And unfortunately, as a trust, we have had some increases in that in the last year, and that's the sort of national picture as well, with the exception of Klebsiella, which we have had a reduction in. But 17 is under our national trajectory for that. C. difficile, unfortunately, again, we've got a national trajectory for that, and we've gone 2 over that in the last year. Significant increases in terms of C. diff across the country, and what we're hearing is a sort of back to the 2008 time of where we had huge infection rates from a C. difficile point of view. So what are we doing as a trust? Over the last year, we've had a number of initiatives which I think, had we not had in place, would be in a much worse position. Gloves off. During COVID, we've seen a huge increase in glove usage. I mean, you would have seen it in supermarkets as well. Everyone was wearing gloves. We have achieved a 30% reduction in glove use, and that's been a real focus project at the IPC team. From a bloodstream infection point of view, which is where most of our infections come from, lungs and tubes and drains, we've had a real focus on skin decolonisation with antimicrobial washes. And that real focus on that. We have employed a number of home-free care nurses, which are doing some focus work on wards that we know that have had issues with catheters, for instance, and lines, and making them on the wards and delivering that education so that we're able to, you know, that we've got that accessibility for staff when it's busy. And that we've seen that sustained reduction in those areas. From a CDIP point of view, we invested in 4 new machines, so that we'll have that real pressure in the last year on beds, with constant occupancy of over 90% continually. And we know that from an infection control point of view, 85% occupancy is really where you need to be. But looking at that, we've also it's that early detection, that monitoring of stool samples, and that antibiotic prescribing audit that we do on a monthly basis, and we're really looking at that now and working with staff and prescribers to reduce that. From a grand negative bloodstream point of view, we have got a steering group now. We're looking at community cases and got that deep down, and we'll work with teams and boards that have got it.
Thank you. And next, I'm going to talk about abnormal results. We know that management of clinical investigations is a patient safety issue across all healthcare systems. And we know that there can be unintended delays across the ordering process, which can ultimately lead to delays in patient treatment. So the aim of this priority was to try and improve our investigation process for 2 particular types of investigations, and they were mainly around MRI scans and CT scans. And the aim of this priority was to ensure that we get the right results back to the right clinician at the right time to ensure timely treatment. It sounds like this would be a relatively straightforward issue to try and resolve, but actually there's been quite a bit of complex work trying to improve and align 3 digital platforms that are all involved in the investigation ordering process. But I'm pleased to say that the digital team have worked very effectively with our clinicians, and they have improved the ordering process. And from the results that we got during the time of this pilot, we have been able to extrapolate that if the success of this pilot was introduced over the course of a year, we would actually improve the reporting processes of our MRI scans by 22,000 patients and improve the reporting around 48,000 CT scans. So you can see that this piece of work has had a huge impact on patient safety, and the plan is that we will continue this quality priority into the coming year, so we can look at different ordering streams and also explore the options of use of artificial intelligence in our results process as well.
Thanks. So priority 3 is enhancing the capability and quality improvement. And we chose this really because we wanted to make sure we created a culture of continuous improvement and learning across the trust to deliver real improvements in the quality of services we provide and the experience of care. We recognised that in order to do this, the training of staff in quality improvement was really essential to embedding that and getting that to happen in practice. And what we needed to do is, working with the Institute for Health Improvement over the 2 years, we've been trying to build up our capability to deliver quality improvement training to staff. And what we've managed to achieve is we have recruited over 10 improvement teams, and each team consists of around 4 or 5 members who go through a project of quality improvement and gain skills in quality improvement. And they'll have those skills embedded when they move on to the next project. And we've also managed to recruit 25 improvement coaches, which are coaches which can coach through the journey of quality improvement and support teams with their quality improvement projects. And We've also been aligning this with the Institute of Health Improvement in terms of our programs of what matters to you, and the Newcastle Way, which is our leadership behaviours, and we embed that into our ongoing training packages. And we've also managed to develop bespoke bite-sized training, which is accessible training in different parts of quality improvement, and staff can attend. They're short, snappy sessions that staff can go and really find out more about the parts of quality improvement they need to know about. We've included an enhanced induction so that staff who are new into leadership roles can really find out more about quality improvement. And we've also developed e-learning packages as well, so staff can access in their own time or when they need to, a time that suits them, the methodology they'll need for quality improvement. In addition to having learning and sharing events where we will share people's experiences, often positive but challenging of quality improvement, so people can learn from other people who are already doing quality improvement in the trust. And what we've seen is that in terms of taking the quality improvement approach, if we just go to the next slide, we've seen the quality improvement being embedded into other projects. So, for example, priority core A is the introduction of formal triage process onto the maternity assessment unit, MAU, in order to improve the recognition of deteriorating pregnant or recently pregnant women. And we recognise this was important because through the Ockenden report and through Embrace, which is Mothers and Babies Reducing the Risk of Audits and Confidential Inquiries, had identified that this was an issue that could be improved. And we also had a series of incidents and significant learning events where we had recognised that recognising deteriorating pregnant or recently pregnant women would have had an influence. So we wanted to introduce a formal triage process onto MAU where we identified within 5 minutes of arrival on the MAU, 95% of pregnant or recently pregnant women had a triage process by a trained member of staff. What this, in terms of what we've been able to achieve, there has been ongoing and important improvement work on this project. One of the things we've managed to achieve is that we've looked at the telephone call queue. So previously we had lots of calls coming into MAU, and we've now been able to create a telephone call queue where calls that come in, be it scan appointments, induction or cesarean section, will get sent to the correct person to deal with that inquiry. So it's not coming straight through to MAU staff. We've also developed the maternity daycare unit on Ward 41 in March 22, and this is staffed between 8 AM and 4 PM by a midwife, and also is supported by a consultant obstetrician who is around between Mondays and Fridays in the afternoon, who can support the staff to work with women who are unwell who are attending. We have appointed a Band 7 midwife for the MAU, commenced in January 23. It's been really crucial to provide leadership and ongoing development around triage education in the unit. And in terms of the other developments in the unit, we've moved to a digital solution called Badgernet, which is a note solution, but within Badgernet it has a triage solution built into it. So whilst we've developed a process and looked at triage on a paper-based system through the IHI project on triage, we've also got an electronic solution called BSOPS, which is within Badgernet, and we'll be looking to introduce that as Badgernet is implemented on January. So Badgernet has started, but we'll be implementing the triage component of Badgernet as well. Well, we've done snapshot audits of triage and MAU. We've identified that we can achieve the triage within 5 minutes, and at times it can also be challenging. So there's more work in order to going on to develop that as a sort of a solution in an ongoing capacity. The next priority was 4B, which was modified early warning of obstetric scores. And we've chosen this because we've recognised, and across England, there's been several situations which have led to adverse outcomes for patients who attended outside of maternity and non-maternity units because their physiological observations are different from those that would use in standard observations. And what we've aimed to do is really create a a means of identifying pregnant or recently pregnant patients you attend through our electronic patient record systems. And so we've been able to look at building that solution. And then once identified this group of patients, we can introduce to that group of patients the sort of targeted meows observation chart, which links into their observations. What we've been able to do so far is introduce a digital question so that we're now asking on admission if you're pregnant or recently pregnant, so we can identify you first and foremost. And the second part in relation to that is that we're moving into a coding and testing part around the IT solutions and how, once we've identified you, how we then link into how we'll actually put you onto the correct chart. And that's taken further digital work to make sure that's a really robust solution. We're expecting that to come online this month. And what we'll plan to do is, once it goes online, we'll be looking to audit that solution and make sure it's working effectively.
So our day surgery initiative came around as an organisation because we recognised the possibility of making more of our patients day cases as opposed to the more traditional model of being overnight stays and having longer length of stays. We knew that would reduce our bed days, our waiting list, and improve patient and staff experience as well. So there's been a lot of work gone into this, and it's something that we're really proud of, I think, and it's become business as usual over the last 12 months. And a lot of that is revolved around our new day treatment centre, which is at the Freeman site. So just a snapshot really of what we've achieved in that 12 months. We've now developed a universal waiting list, which is modelled on national guidance, making sure that the right patients on the right place on that waiting list, so they get seen at the most optimal opportunity for the surgery they need. A huge amount of work has gone into our pre-op assessment service, and there's a number of initiatives that have made this a success really. So we now have a pathway that our healthcare systems lead on, and they're low risk patients. And that's created about 80 new slots a month, which we wouldn't have had previously. We now have a telephone pre-assessment clinic, so patients that don't have to travel into the Freeman Hospital can have a telephone appointment. And that's really increased our capacity to nearly 50%. And we've also developed some new clinical criteria where patients are assigned a traffic light system based on their risk, and that relates to how suitable they are surgically for day case, medically, but also socially. So have they got that right support at home to have a day case procedure? And traditionally, when patients had day case operations, we would always say to them, the evening of your operation, you need somebody with you at home. But we've introduced a new initiative called Home Alone, where certain patients, where it's appropriate, don't have to have that level of supervision on the evening. It just allows us to get that flow through safely, but more efficiently. And then the third improvement in line with this priority really is use of what we'll call the 642 model. So again, that's a national scheduling tool where we make sure our theatre lists are set at 6 weeks prior. Our clinicians' annual leave are set 6 weeks prior. We'll have the theatre list 4 weeks prior, and then everything's checked at 2 weeks. And that just has meant that the theatre list we do have available are utilised as much as possible, and there's a lot less cancellations or last minute changes, which obviously is better for our patients too. And that's alongside a care coordination system, where previously you would be trying to schedule patients in using different clinicians' diaries, different theatre availability sheets. It puts everything in one place, so it just means that people doing the scheduling got everything at their fingertips at the right time. And it just makes it a more smoother and more efficient process, really. And that's seen us make massive improvements in terms of our day casework. I'll pass you on to Helga.
Thank you. Priority 6, children and young people's mental health. Why have we picked this? Well, we know 1 in 6 child or young person may have a mental health issue or diagnosis, and that's significant. And we know that there's huge demands on our colleagues in CNTW in terms of supporting and the services they can provide, in particularly inpatient facilities. So we need to make sure as an organisation that we've got the services in place when these young people present at our ED, and when they present at ED, they're in crisis and they've got nowhere else to go. So we need to make sure that we've got the skills to support these young people until they're able to get the mental health support that they need. So what we wanted to achieve, one of the things was an effective pathway on their journey when they present acutely in our organisation. And we haven't got the services the same for children and young people as we're having adults. And that's a lot of work that we've been working closely again with our colleagues in CNTW. What should that look like? How do we get investment for that? How do we make that happen? We've now got somebody in place, somebody who works for CNTW, that will be working on our site with our staff, with our children and young people that present, to look at those pathways and how should that look and what services do we need on site 24/7 to support the young people. That is going on, and that will be a piece of work throughout the next year. And hopefully in a year's time, that will have been done and we know exactly what that looks like and what that investment is. But that person also is somebody who's on site to give the support to the staff and the advice to the staff. So that's really a significant improvement. We want to make sure, as I've said, that the staff are appropriately trained to look after young people, children and young people that present with mental health issues. We're general nurses, we're not mental health nurses. And so we've got a fantastic relationship with our colleagues in CNTW. We will offer clinical training across at Ferndale, and likewise they'll come across to us and they'll support us with training the staff and talking to the staff about mental health disorders, diagnosis. We've also had a really good year with a programme called We Can Talk, which is a nationally recognised programme, and it's training that's delivered by mental health play staff, but most importantly by young advisors who've had lived experience. So that's twofold. We've had 2 members of staff go across and work with the organisation, work with the youth advisors, and come up with 2 initiatives to support young adults presenting in ED and young people presenting in ED, and they've evaluated really well. Simple things. Information when a young person arrives: we're glad you're here, we want you to be here, and we're going to look after you and keep you safe, and some information on services they can access when they're discharged from hospital, and also reception, a little card. We can talk in private, and the person just has to hold this card up, and the receptionist will make sure that they go somewhere private to have that conversation if they don't want to have that in public. Simple stuff, but really effective. The other part of the training is an online 6-hour module that can be done dipping in and dipping out. And that's really listening to the experiences that young people have had and learning from their experiences, what works well, what doesn't work well. And we've encouraged not just clinical staff to do that training, we've encouraged security, portering, ward clerks, anyone who comes into contact with a child or a young person, we've encouraged them to do that training. And that again is evaluated really well. So we're really pleased with that. We're looking at the environment. Is the environment appropriate for somebody that comes in crisis? It hasn't been, so we've been doing a lot of work to make sure that we can make the rooms more supportive, more conducive, and have stimuli there, or no or less stimuli, and also an environment where they can be kept safe, because often these young people are extremely anxious. We'll continue to make sure we've got the assurance that we need, that we're meeting national standards and CPOD standards. So we have got a well-established children and young persons mental health strategy group that just continues to look at, are we meeting those standards, and actually what else can we do over and above. And I think that's probably it from a mental health perspective. Final priority that we want to talk about is reasonable adjustments for patients with learning disability and or autism. Why have we chosen this? Well, we know that a person with a learning disability is 4 times more likely to die than somebody who doesn't have a learning disability. And it's important that we have got the services in place and continue to review the services we've got in place to make sure that we appropriately support people that come into our organisation with a learning disability or autism. what did we want to achieve? Well, we have a learning disability team. We were keen to look at that. Have we got what we need to deliver the services that we need in that team? We have had investment, which we're really pleased about. And we've jiggled with the skills in that team. So we haven't got a team that's made up purely of learning disability nurses. We've got clinical nurses with a background in learning disability. We've employed a play specialist into the team, which is proven really, really beneficial. And we'll have a support worker in the team, differing skills to support staff in different ways, and also to have people out and about on the wards, seeing the patients, talking to the patients, and also talking to the staff. And that's working really well. Assurance that reasonable adjustments are in place. We'll often do this. We'll put reasonable adjustments in place, but we might not document it. And there's a lot of work ongoing around that. We had a very successful Learning Disability Week last June, and we talked a lot about reasonable adjustments with staff, made sure that there was lots of posters go out to the staff. And we'll continue to do that, and we're working very closely with the North East and North Cumbria Learning Disability Network, and there's a lot of work and projects and thoughts ongoing around reasonable adjustments and interactive posters that'll have a QR code to support patients and families, and apps to support that dialogue and sharing of information on a person's passport. And as a result of all the conversations we've been having about reasonable adjustments, Learning Disability Week is in June this year, and as a region, the organisations are going to work together on promoting reasonable adjustments to be collected through the A2A network, which will be really good. And we also need to ensure the staff have got the appropriate training around learning disability. There's been lots of ad hoc training that we've done, and our learning disability team do forums so that staff can share experiences and types of things that are done in terms of reasonable adjustments to support a patient coming through the organisation. We have implemented electronically what is called the Diamond Standards training, and that was a training package that was developed by the A2A network. So that's our regional training, and that's been implemented. There is more training to come. We know it's going to be mandated probably in the autumn, and that will require additional training, which is face-to-face, and that's national. That's on the back of the Oliver McGowan training that some of you may have heard about. So that is something that will be progressing as the year goes on and as that mandate comes out. Thank you.
Last slide. Thank you, everyone. That was brilliant. So I hope, whilst that's been a very, very quick overview of the quality priorities from this last year, I hope it gives you a good flavour of some of the improvement work that's been ongoing to improve the quality of care across the trust. You will see from this last slide that some of the priorities are continuing from this year, and there are some new ones on there as well. You probably won't be surprised to see the National Patient Safety Strategy and the new Incident Response Framework. That is something that, as an organisation, we are already working on our implementation of that. That really focuses on helping staff do the right thing at the right time, promotes good psychological safety. So as an organisation, we have a healthy culture and we're open to learning, that we involve patients and staff in safety, and that we have the right metrics and measures to help us know when we've made improvements to our quality systems. And all of that is underpinned by improvement work as previously described by Gavin. I'm going to hand over to Helga for the last couple of points around the other new priorities.
Yeah, so in terms of I talked about children, young persons, mental health. We're focusing on children, young people and adults, and the environment in ED and the services that we're providing in ED. Are we triaging right? Have we got the right support for these people? Is the environment right? That's something we'll be focusing on this coming year. And also transition. So young people that transition from children's services to adult services. We need to embed, there is a nationally recognised Ready, Steady, Go, Hello programme. It works really well in certain specialities. For instance, rheumatology, it's an easy transition. But if a child is complex, if they have mental health issues, if they're into safeguarding, it's not such an easy transition. So we'll be working hard this year to improve that.
Thank you.
Are you happy to take questions?
We are.
Yeah. Councillor Hill.
Thank you. If we look at the actual accounts themselves, page 108 in our pack and 76 in the quality accounts, and this is a list of national priorities, targets, and the performance of the trust. There's about 16 here, and all but one, the trust's annual performance is less, and in some cases significantly less than the national target. If you look, for example, and there's many things that stand out and are shocking, all cancers, 62 days wait for first treatment. So from an urgent GP referral for suspected cancer, the national target 62 days. And the target is 85%. So 85% of patients to be seen in 62 days. The trust is 53.1%. So that's almost half of patients are having to wait longer than 62 days to get, after GP says, yeah, this is important that you get some treatment early on. That is surely, I mean, I'm looking at, we all know this, we all know the urgency and importance of getting an early intervention at cancer. I mean, I'm reading Cancer Research UK, spotting cancer at an early stage saves lives. So it's important to tell your doctor as soon as possible if you notice anything that isn't normal for you. So obviously, this is risking life. People will die because they're not being seen enough. None of this was mentioned in the presentation, and you know, I don't like to overstate things, and I don't think I'm overstating by saying it's a crisis here. And I'd like to, I know it's a formal report, so you don't maybe get the sort of sense of urgency coming through, but I'd really like to know what the plan is to up the game, because the performance against the national targets is very poor, and cancer treatment targets is extremely poor and desperately worrying.
Yeah, so in terms of the across the board, in terms of cancer performance, the initial focus after the pandemic was restoration and encouraging people to come forward, go to the GP and get referred into the service. So there has been some specific challenges with the 62-day backlog, and within that you've got some really challenged specialties in terms of capacity. So some of the large deterioration in the cancer 62-day performance is towards the dermatology pathway. We are a regional provider of dermatology services. We have significant backlog of numbers to work through in terms of patients and getting a diagnostic biopsy through. We saw that number increase to about 400 backlog in October. So we've been working hard to put some additional capacity in, work with our neighbours, their own private dermatology service, and we've been working with some in-source companies to get that capacity in, see the patients. It does push some of the routine patients back to prioritise the cancer pathway patients, and we've seen that backlog come down to around 200, which is our pre-COVID pandemic level. So we're not there quite yet in terms of the performance, but we've certainly got our backlog down. So we're just working now through what that means in terms of sustaining that. We've also got prostate urology pathways in there as well. So again, some of those aren't particularly a high priority in terms of prostate cancer, in terms of business treatment and management treatment. So again, we've been working hard to get those backlogs down as well over the course of the last, probably about the 4 to 6 months to bring those down. So it is a priority for the trust. I suppose we haven't pulled it out as a specific priority because it's a priority part of that recovery, part of meeting real constitutional standards across the elective recovery programme, but also cancer standards and the A&E standards.
So next year, and it's obviously not much consolation for people that are waiting and severely impacted, even catastrophically impacted because of not being able to get treatment. But next year, that 53.1 figure will be a lot better.
So we are working on improvement, and absolutely the national focus is around the backlog. nationally, we have a specific targeted planning guidance to reduce that backlog. And what we're making to bring is, so if I bring that back to Glen, we'll bring about achieving the performance percentage.
Is the quarterly updates on this? I mean, it'd be quite useful to see in a quarter how that's going.
Yeah, the council performance are included in the public board paper.
Right, so we could pick up from it.
And there's regular scrutiny of our performance through the integrated care board. So that happens throughout the course of a 12-month period.
Yes, just a couple of questions on the tele-appointments, the telephone appointments from pre-ops. Are you trying to give them out as much as possible? I'm just thinking of the ones that sort of through the north area, if I had to travel down to Newcastle and Cranmont and that for pre-op. And it's a case of, I know some situations they will need to be face to face, but as much as possible, is that an automatic that you will try? And the other question I've got is on the mental health. I appreciate you're talking about the high level, but the schools are reporting since COVID, there's a lot of low level mental health. And I think if we can try and get in there and catch that and try and put something into support so that it doesn't get to the crisis point,
That's right.
you know, as much as we can. That's two questions.
I mean, I think for the day treatment centre, absolutely. When we get a referral for surgery, my understanding is the team will triage that, and for everybody who they can get through that telephone pathway where it'd be safe to do so, they will. Because you're right, we're a regional centre, so we get patients from Cumbria, like you say, very up north. So yeah, where we can do, we try and optimise that as much as we can.
And I think when you know, when it hit, we very quickly had to implement a system of tele-consultations, and actually as services have been reinstated and as the COVID situation has improved, we've had a bit of time to sort of review and reflect on that model and across the wider clinic base. We have moved to a mixed model of face-to-face consultations and tele-consultations where they are appropriate.
Thank you. Any other questions? Jenny? Right.
Yeah, thank you for that. I think that was very comprehensive and it's very interesting. Just a couple of points really. I suppose from the presentation, and I've deliberately not read the full account until I've seen the presentation, I was just wondering where the patient experience metrics are on this. I think some of the presentations you made about things where you've been improving on, looking at maternity stuff there. Where are you saying, well, actually, this has made a difference to patients and we know this because at the end of the day, that's the thing that matters. And so I'd like to see something about that within the report and the presentation. So is there anything about that is there anything from any of your perspective that you can tell us today that you can say hand on heart, actually, the feedback we've had from a patient, because we've done it this way, whether it's appointments or whatever, that's got improved? That would be good.
We work specifically with the family in terms of the environment that I talked about in PCD, in the assessment unit, whether it's for a number of weeks. It was less than ideal, and we've learned from that family and worked with that family. And we've also looked at the information that we give to families when they leave the acute trust and are transferred into mental health inpatient. It's a very different experience, isn't it? Very different. And so it's preparing. We learned from that case as well. So again, we've worked with this family. Actually, we need to prepare these young people and their parents better. So yeah, that probably is an example of why. I know we've improved in that from the family.
That's exactly what I think we're looking for, because I think one of the things that I think other people sort of mentioned this as well, from a Northumberland perspective, obviously some of the challenges of the Northumberland patients with accessing treatments and services in Newcastle is really difficult. And again, you know, I was thinking about it was good to hear about the mental health case, because I was thinking when you were talking, how many of the young people in ED are vulnerable. And similarly in maternity and all of that. So again, it would have been, I think sometimes with this, it would be a reassurance to us as health watch Northumberland and local members to see the Northumberland patient experience reflected within this. Because you know that there are barriers to varying services and that people don't always feel that it's easy for them.
And, you know, I acknowledge what you're saying and that you do have yes, different challenges from the sort of rural location in Northumberland. We do have patient relations team within the trust, and they work with multiple specialities, and none of us are actually directly involved in that work, but obviously all of us will overlap with that. But I think in line with the patient safety strategy that we're implementing, we're very much wanting to focus on the experience and the involvement of patients to help us with co-production in the future. So we will have patient safety partners and involved in some of our key patient safety work. Helga and I are involved in development of the mental health strategy, both for adults and children and young people, and we have service users as part of that to help with that co-production. But it's a good question. Or in that work, have we considered the sort of wider geographical location? And that's certainly something I can feed back to the patient relations team.
Thank you.
No question, I was going to come in. Just a response to your question as well. Was within that 62 backlog in terms of cancer service, the Transportation Centre, that we are reliant on receiving an early diagnosis and diagnostic result from a outlying trust before we then receive the patient and then have them treated within 62 days. So it gives us a very small window to kind of meet that target. But one of the things we've been looking at with the Cancer Alliance, and it's something again we can probably involve the patient in, and then work with yourself on how we do that, to encourage patients to have diagnostics somewhere else other than their local trust where there's capacity. Or actually didn't get them in for an MRI, could directly pass on rather than Northumbria. If it had come along that cancer pathway and get that diagnostic, it helps us with the 62 performance as well. And probably some work we can do around if they're at that level.
If they can get there.
If they can get there. And if they would like to go there.
Yes, exactly.
We know patients like to go to local hospital as well, so they have space out in the road.
Thank you. Right, well, thank you very much for coming. It was the actual document, the document report with it was very full, which has left us not a lot of need to ask questions, I think, is very good. So thank you very much. You're welcome to stay, but I suspect you'd like to go.
Thank you. Thank you.
The arrows, you even. That's you got a good start, as if you can't move it.
I ran for no help. I'm so sorry.
Yes, so the next item on the agenda is the Cumbria Northumberland Time and Way NHS Foundation Trust, commonly known as CNTW Quality Accounts, and we have Chloe Mann, who's the group director, who's going to take us through the presentation.
Thank you very much, everyone. So as you're aware, this is part of our annual process. Hopefully over the next few slides, I'll be able to provide you with some key headlines, an overview of our delivery against last year's priorities, and looking ahead to at what we hope to achieve, and importantly seek your feedback on what we're proposing. So I'm aware that we wouldn't usually start our presentations with data on a slide, but it's really important just to set the scene in terms of what we're going to be talking about. And this linked to the quality priorities that we set last year, which we haven't met. So in terms of Northumberland, the majority of people on the waiting lists across all of our services sit within the adult ADHD diagnosis pathway and adult ASD pathway. They account for 22% of the total waiting list. Children and young people's service account for 14% of the total waiting list, and all of our other adult services account for the remaining 23%. This includes adults and older adults in our community mental health teams. When comparing the waiting list position of 2021 to 22 and 2022 to 23 for adult ADHD and ASD services, you can see there's been a significant increase in the number of people waiting more than 18 weeks for a diagnosis, as well as a significant increase in the total number of people waiting to be seen. The ADHD was 543 compared to 1,546, and ASD was 289 compared to currently 811. There isn't sufficient flow through these services, and that's due to the requirement of service users needing to remain on our caseloads for yearly medication monitoring. It means it cannot be discharged, which impacts on the capacity of the team carrying out the assessments and diagnosis. In terms of the Northumberland specific area, just to add, our North Commissioners have tried hard to support us by funding a 2-year waiting list initiative for a cohort of less complex patients to receive their assessment and be titrated through Psychiatry UK. We've got significant pressures across the organisation in relation to waiting times for adults and children with ADHD and ASD, but it's something that we're also seeing nationally, which we know requires a fundamental review. And commissioners have started task and initiatives in relation to this. We know that moving through into community mental health transformation will benefit us massively, and it'll ensure that we're seeing patients at the earliest opportunity by the right person at the right time to assist with their needs. So year in numbers continued. Northumberland Children Young People Service continues to perform very well, with being very few people waiting over 18 weeks to treatment. There's been an increased pressure within 2022 to 23 due to an increase in referrals in the last quarter of the year, which has been maintained, the last quarter of 21 to 22, which has been maintained. It's over double the referrals that we've seen previously. Our team have been working tirelessly to ensure that the over 18-week wait position is recovering and continue to strive for the new 4-week wait treatment standard. Biggest pressure within the area of Northumberland Children's Services is within the neurodevelopmental pathway, and work is being carried out internally to review that. At the end of Q4, we had 9 people waiting over 18 weeks, which is significantly lower than other areas across the trust. So looking back at our quality priorities, which we set during 2022 to 2023, there's been lots of good work so far, but there is still further work to do, and we've been very honest in our assessment of our priorities in terms of them being partially met or not met at all. For quality priority 1, in terms of improving the inpatient experience, this has been partially met. Work has been undertaken around our purpose of admission to ensure anyone who is admitted to our wards has a defined treatment goal identified about what their admission should achieve. We've been reviewing our minimum and safer staffing levels across all of our wards and refreshing them to what the current requirements are for the complexity of patients that we're seeing. We want to ensure we've got safe, effective and high quality workforce, and we're working hard to reduce the need for temporary staffing and our need for agency staff. And finally, we're in the process of defining our therapeutic offer for inpatient stays, looking at the wider multidisciplinary team and skill mix. We're in the process of relaunching our quality frameworks, which is a national driver, and the trajectory to 0 out of area bed days was not met. However, progress has been made in identifying and reducing people travelling more than 50 miles for an inpatient stay. So we weren't able to confidently say we had met that as a whole, but progress has definitely been made in all areas. Quality priority 2, service user and carer experience, looking at improving our waiting times and making sure our service users and carers are being heard. So like I've just said, the North locality remains in the best position across our trust for our waiting times. However, other areas do remain a challenge due to increased waits for adult mental health increased referrals, including autism and ADHD. Gender dysphoria waiters are waiting significantly over 18 weeks, and children and young people services have seen a huge increase in referrals, leading in the increased waits for treatment. We're working really hard to hit the new 4-week waiting time to treatment target, which is going to be coming into force. And as I say, working very closely with partners right across the system, including primary care and third sector colleagues, to ensure we're working in a much more integrated way, will ensure that we're delivering the best care possible at the earliest opportunity. So we've said that we didn't meet that quality priority. In terms of quality priority 3, partially met. Our service users and carers being heard. We've increased our peer support workers across all of our services, both inpatients and in the community, and we've introduced carer support lead roles, 1 per area of inpatients, community and access, to give dedicated support to our carers. We continue to operate and work within the framework of the triangle of care, making sure our service users, carers and our staff are collaboratively working to create plans of care and deliver what's required. We've relaunched our Carers Promise at a carers event earlier just last month, and we have a real focus on timely admission for those patients that have been detained under the Mental Health Act, and we're working hard to develop crisis alternatives in the community, including a safe haven based in Northumberland. Efforts have been made to make feedback more accessible for people have been successful, with increases in complete surveys, and gender dysphoria services are now using the main survey after co-developing more inclusive demographics, with people using the service You Said We Did posters. So we developed those in terms of what our service users and carers have said and what we've done, and we have them displayed across all of our inpatient areas and community bases, so that feedback can be seen. But priority 4, we've got this as a partially met priority. We continue to focus on human rights and reducing our restrictive practice across all services. We're working hard to address inequalities and ensuring our services are able to meet the needs of our local population and communities. We're working to establish metrics to monitor inclusive recruitment effectiveness, and which is still in development, and service users and carers facing where it needs more focus. So looking ahead at our quality priorities for improvement, in terms of consultation and engagement, we've had 4 stakeholder events, both online and in person. We've had a survey asking stakeholders what their main priorities are, and we've had 444 responses to that. And we've had a review of the service user and carer feedback themes from over 3,400 surveys between November 2021 and October 2022. So we really want to make sure that our priorities going forward are really inclusive of what service users and carers need. So in terms of next steps, the proposal we're making around our quality goals cover the 5 different areas outlined on the slide above there. In terms of safety domain, we want to continue having a focus on restrictive practice, working hard on ensuring our care and treatment offer is trauma informed. We're continuously reviewing for closed cultures, as you'll be aware throughout the media that there's been programmes aired over the last year, which are of great concern. In terms of effectiveness, therapeutic offer, engagement and observation. So there's a real focus on engagement of our service users when they're required to be under a level of observation on our wards. We know that often service users will require that one-to-one intervention, and it's really key that that's an opportunity every time for real engagement and therapeutic work. Linking closely with this therapeutic offer, there's the hope that this will reduce our incidence, and we've launched a new e-learning training package in February this year to support staff in terms of looking at effective engagement and observation. In terms of experience, we still want to continue with our waiting times for children and young people. Like I've said, Northumberland are working really hard on that metric, but we know it's going to be a real challenge going forward and continues to be across the organisation. We need to have this continued focus and work very closely with our schools and those who support special educational needs to make sure our children and young people are getting the earliest intervention possible to try and prevent further deterioration. well led. We're going to be implementing our PSERF, which is a national framework for the reviewing of serious incidents and patient safety incidents. It's really effective in terms of learning and improvement, and this needs to be rolled out by autumn this year. It's a completely different approach to how we currently review and investigate, and it will aid us to get family engagement and support right, support this process, the trust and the process of recruiting family liaison workers to support families throughout periods of need. We're going to continue to have a constant focus on close cultures. Like I've just described, we know in the media that there is a risk to mental health services in terms of close cultures, and we want to ensure that our clinical leadership runs through like a golden thread to really ensure that that isn't the case. And we're finally on that point, we're doing a full governance review to ensure that we're reporting things in the right way and making the correct decisions. Our final priority proposal on there is around our use of resources. We really need to get the quality right. It goes hand in hand with patient safety. We're looking at how we recruit and retain our staff and make sure they've got the right skills that they require to do their job successfully. Is there any question?
And can I just compliment you on a very clear presentation? That was long and easy to read. So thank you. Questions?
We haven't actually got the accounts, so.
No, the report will follow later this afternoon, I believe.
All right, so,
Up to the main one.
yeah. No, I agree, there's a clear presentation with some really specific recognition of problem, areas of improvement, so interested to see the accounts themselves.
Yeah.
Yeah.
Questions? No? No? Perhaps when we've seen the.
Yeah, absolutely.
Yeah,
I did
yeah.
expect that it would be with you prior. It's my first time, so I do apologise. And when I checked, I was made aware it was coming this afternoon.
Can we email questions on the desk? Would that work?
Yes.
By Chris,
Yeah.
maybe, would that work? Can you do that? Email any questions to
Yeah.
Chris, and yeah.
So if you're happy with that, then just say.
Yes, absolutely. That's fine.
Yeah, because we will do a report, so we need our questions to go in it, really.
Yes, yeah.
Well, thank you very much. Councillor Bolton.
Yeah, can I just make a comment? I think it needs to be said. Basically, you do a fantastic job. It must be difficult dealing with young people with mental health issues, and their families are complex. And I know that you liaise with schools and you liaise with families, and we often read in the newspapers of some person who took their life, some young person, which is tragic, and that has a ramification, not just in their family, but in schools and in their communities. So I take my hat off to you. It's a really difficult job to do, and it'd be nice to get the waiting list down and get people seen to learn, but yeah, keep up the good work.
Thank you. I think we all got along with that, yeah. So thank you very much for coming. Again, you're very welcome to stay. Sorry,
Just a very simple question. Sorry, Chair. I just wondered, have you seen much of an increase in self-harm in young people?
I wouldn't want to quote figures without having them in front of me, but in Northumberland we do have very robust services for children and young people, which obviously cover the point of from liaison in NSEC Hospital all the way through the Universal Crisis Team, and we are seeing increased referrals across the board for children and young people.
Right, I think that was definitely the last one.
Yeah.
So yes, again, you're welcome to stay, but if you'd like to go, thank you again for coming.
Thank you very much for my
And we'll come back to you on those questions.
Perfect. Thank you.
Thank you. Item 8 is the report of the scrutiny officer. I'm going to pass over to Chris Angle.
Yeah, you'll notice the work programme isn't included in the pack. That's because it's come to the end of the council year. And the new work programme is currently in draft. And my plan is, if the committee is happy, is for me to share the work programme after the AGM on the 17th. Once we've had any discussions about the new ways of working and how Scrutiny will work throughout 23-24. And so once that's agreed at the AGM, I will share the draft work programme with members at that point. And then I think it's only about 2 weeks before the first meeting in June. So at that point, then we can have a discussion about the work programme then.
We're all happy with that, councillor Heron.
I was going to mention this potentially in item 9, but I might as well mention it now. You may have seen in the paper, you know how we had the debate, we had it last year and this year, about breakdown of ambulance response time figures per local area rather than just aggregated to the whole North East Ambulance Service area. We've always said we can't give that data. Well, I did an FOI and I got the data. I think that caused a bit of consternation. I think the question was, how did you get that data? But they answered it, and it was TD15 post code. What's the average response time for this area in the last year? And it was 3 minutes longer than the national target, under 10 minutes, and 2 minutes more than the average in the NES area. And to be honest, it's not great. I thought it'd be even worse. You know, how defensive they were and didn't want to give the data. So that's certainly blown a hole in their argument that they can't break down the data. They can. It's just a case of going on a spreadsheet, putting in. So I think it would be reasonable for us to ask what it is in all the other areas, wouldn't it? To see that, because that gives a picture of what's going on. I mean, I think we've had particular problems in the north. So I don't know, but it would be good to get to see it across the piece, wouldn't it? They can't really realistically now say we can't give you the data. It came very quickly. It's not even a lot of work for them to gather. It's a simple going in the spreadsheet and get that information.
We'll include that in the work
Yeah,
programme.
definitely. Yeah, speak to NES and
It'd be an interesting piece of work.
Yeah. And nationally, they do that nationally as well. They won't give the breakdown of the data. But I think they need to be a bit more transparent and just give the data so we can analyse it properly and see what's going on.
And the work programme going forward will include the new method of scrutiny, where we, rather than different method of scrutiny, where we will do more in-depth work. Yeah. Anything you want to say, Councillor Patterson? Thank you. In that case, have we any urgent business? No. Our next meeting is, remind me, please, it's June.
I think it's the 2nd of June. Again, the timetable of meetings for next year will be approved at the AGM, which is why we haven't published it, because in theory, it could still change. It shouldn't do, but it could. If it doesn't change, the next meeting will be the 6th of June.
6th of June. Right, in that case, thank you very much for coming.